I'll start my slides. In meanwhile, we will join others. Okay.
Okay, ma'am.
Sure. Thank you. So this is a little bit long class. Okay. So we have to be a little bit patient. I'll try to go. So good afternoon. So today's topic is bronchial asthma. So bronchial asthma is a chronic inflammatory disease. It is characterized by episodic hyperresponsiveness of airways to various stimuli, which leads to widespread narrowing of the airways. And it results in reversible airway obstruction. So the word important is reversible. Hazur?
Light change bhayरहेछ
Hello? First slide मात्रै छ हो
हजुर म्याम
मेरोमा चेन्ज भयो हेर्नुस् त अब भयो
भएन म्याम
भएको छैन म एकचोटि फेरि स्टप शेयर गरेर फेरि झर्छु है अब भइरहेछ can you see right now changing
No, ma'am.
Okay, what if I keep like without that
Projector mode मा राखेर हेर्नुस् न ma'am.
yeah a little mode मा राख्नु पर्ला this way does it change
Yes, ma'am. Yes, ma'am.
okay okay I'll try to make it little bit big okay does it change right now
Yes, ma'am.
okay thank you so much okay now I'll start again so so bronchial asthma is a chronic inflammatory disease. So the word chronic is important, inflammatory. So it's something that is occurring because of inflammation, okay? And it is characterized by episodic. So it has multiple repeated episodes, okay? So episodic hyperresponsiveness. So it's a normal response of airways to various stimuli, which becomes more, that is hyperresponsiveness, leading to widespread narrowing of the airways. So the airways become narrow. And it leads to reversible airway obstruction. So something that is reversible with time, it may be short time or long time, reversible airway obstruction occurs, okay? So what actually is there is, it's basically what is the cause, root cause, we don't know. So it's something interplay between genetic and environmental factors, and it can be extrinsic, and means the external environment factors, which is IgE mediated. Intrinsic means something genetic, non-IgE mediated, and sometimes it can be both, mixed. So what happens when you inhale some allergen? It gives a biphasic response. So it can be an early response or a late response, and both of them leads to bronchoconstriction. So what happens actually when there is a allergen which you have inhaled, the airway become inflamed because of some factors like interleukin 4, interleukin 5. Okay, so with these factors, there starts airway inflammation. Because of inflammation, what happens? There is edema and inflammation of mucosal linings of airway. So whenever there is inflammation, always there will be some kind of edema that leads to edema of the mucosal line of airways. Along with that, with inflammation, there is secretion of mucus, and there is spasm of smooth muscles of bronchi. So all three of them, that is edema, secretions, and spasm, all of three help to reduce the airway diameter. Okay, so airway obstruction occurs. So if you see a very explanatory pathogenesis, then you will find that genetic factors and environmental factors. So in genetic factors, HLA gene mutations of the bronchial airway epithelium, all these leads to atopy. So first exposure, that is first exposure to the triggers, it helps in the sensitization of the helper T cells, which leads to stimulation of B cells to produce IgE. And when there is a second exposure in the early response, which occurs nearly at 0 to 2 hours, very fast. Whenever we do some inhalation, early is very fast, and delayed is, see, it is also very fast, 4 to 12 hours. So though the name is early and delayed, but it's within hours only. So what happens in early, there is allergen cross-links the IgE on the mast cells, which leads to fast mast cell release of histamines, leukotrienes, and other inflammatory mediators, leading to vasodilatation, causing edema, increased mucosal secretions, and bronchoconstriction by the smooth muscle contraction, leading to airway obstruction. But in delayed response, what happens? The activated mast cells and helper T cells, they release cytokines. Okay, so early response is by IgE, and delayed response is by the mast cells and helper T cells, which further again leads to similar kind of response. So, but in delayed kind of response, you may see some response in the eyes and nose, that is conjunctivitis and rhinitis, along with the airway problems. So early phase may start within 10 minutes of exposure to the allergen, and it is due to the release of histamines, leukotrienes, and bradykinins from the mast cells. And it leads to bronchoconstriction, and this kind of response can be inhibited by beta agonist like salbutamol. Late response occurs 3 to 4 hours later, and it can peak up to 8 to 12 hours. And it is basically due to inflammation, increased secretions. So this can be inhibited by steroids. So steroid helps in reducing the inflammation and also helps in decreasing the secretions. Okay. So it is again a diagrammatic view in which you see the diameter of the airways. So when there is a contraction of the smooth muscles, it is leading to the narrowing of the airway. Then along with that, the secretions in the airway, that will also plug it more, leading to decreased airway diameter, and the edema of the lining. So more edematous, again, this diameter is going to decrease. So finally, basically is what happening is there is something obstructed in the airways. So which is actually because of not something something like something obstructed there. It's not something. So it's basically the physiology of our respiratory system, bronchioles and bronchioles, which is leading to a feeling of obstructed airways. Okay, so what are the asthma triggers? So generally, most common asthma triggers are viral infections of respiratory tracts, such as RSV, rhinovirus, influenza virus, para-influenza virus, and adenovirus. And allergens can be other allergens can be animal danders, dust mites, cockroaches, mold, pollen, drugs. Some kind of drugs can also produce allergy, and some food. Environmental factors like smoke, dust, strong odor of fumes, and cold air can also trigger asthma. Weather changes, loss of heat or water from the airways, or sudden release of airborne allergen in the atmosphere. So first, loss of heat and water from the airways means if it's a very dry season, it can be autumn or it can be spring. So sometimes when there is a change in the season, the humidity in the air is less, leading to dryness of the airways, and this leads to triggering of the asthma. And sometimes when there is airborne allergens in the atmosphere, like pollen grains, when there is a spring season and the pollens in a lot of pollens in the air, or when there is autumn season, the falling of the leaves and the dry dust in the air will cause some allergen production in the air, leading to asthma triggering. So generally asthma triggers occurs when there's a change in the season. Okay, exercise. So when there is a some people may have as as a trigger of asthma. So what happens during that time? There's a loss of water of when you exercise, a lot of water may be lost in form of sweat, so leading to mucosal hyperosmolality and leading to some mediator release, which causes asthma triggering. Okay, and emotional. Sometimes emotional changes can also produce triggering of asthma. So, so basically, very important is common viral infections in case of our country, because in our country, whenever there is a running nose, mild coryzal symptoms, then the patient of known case of bronchial asthma or a person who is susceptible to allergies, he may get into some bronchial asthma attack. Along with that, these other factors are important, just because whenever we want to prevent the asthma attack, we have to see if these triggers are nearby that patient. If these triggers are there, we have to counsel them decreased asthma attacks. Okay. So triggers can be inflammatory factors, irritants, and others, which we have already talked. So all early childhood risk factors are generally parental asthma. If the parents have asthma, the child may have the chances of hypersensitivity and asthma. Allergies. If the child has other allergies like atopic dermatitis, allergic rhinitis, or some kind of food allergy, then he is more prone to get into bronchial asthma. Severe LRTI. If the patient is having recurrent pneumonia or he had a lot of episodes of bronchiolitis, then again he may land up into bronchial asthma later in his life. During his trial, whenever the child is exposed to colds and he develops wheezing, that is also a risk factor for the child going into bronchial asthma. Male childs are more prone to bronchial asthma. Children who on low birth weight, they are also exposure. Okay, it may be a passive smoker by the tobacco production area. So environmental factors. So clinical features, very common. It is underdiagnosed and undertreated. See it very commonly as adults, but it is nearly same as adults. Okay, adults have different physiology, but it's also very common. We should always try to diagnose and treat the children. Okay. Variable symptoms. So basically, when the symptoms are variable, we are not able to actually keep in mind that it may be a bronchial asthma. So we should always keep something in our back of mind when the clinical symptoms match with a little bit with this bronchial asthma. We should keep it in our mind that it may be bronchial asthma, and we should follow that patient. and it has a chronic course. So as the definition already told that it is episodic and chronic. So a lot of times it's repeated. So we should keep in mind that it may be bronchial asthma. Then only we may be able to diagnose and treat. So the clinical features are intermittent dry cough. So dry cough is there. A lot of time we treat dry cough as just a viral illness or some allergic cough. Okay. So, but if it is very recurrent, so we should keep in mind that it may be some form of bronchial asthma. So if he is having dry cough, we should try to follow that patient again and again. And if the dry cough is very persistent, we should go into investigations so that we can diagnose the patient early. Wheezing. So if you find that the child has cough and a recurrent wheezing is there, then also we should think that it may be bronchial asthma. Breathlessness and chest tightness. So sometimes the child has complaint of breathlessness at night time or in the evening time or early morning time. So and chest tightness, which is more during the night or early morning time, because at the night time sometimes they just complain and parents may not bring the child to hospital, and next day when they come to the afternoon in the OPD, he may not have any wheezing or he may be more comfortable. So if he has a complaint that he's more worse at night, then also you should keep in mind that it may be a bronchial asthma. And some non-specific complaints like he has the fatigue or exercise intolerance or poor sleep. So as I told you, the breathlessness is more at night. So poor sleep. So basically, asthma affects the sleep of the child a lot. And exercise intolerance. Again, we should think that if the patient has some kind of respiratory illness causing these kind of symptoms, then only we can keep in mind that it may be a diagnosis. We can make a diagnosis of bronchial asthma. Okay. So along with that, we should see if it is triggered by some allergen or irritant or viral infections. So if these symptoms are recurrent and worse at night, and if it is triggered by some allergen, we should keep in mind that it may be bronchial asthma. So, in acute cases, generally, there may be significant respiratory distress, and the child may come to you in form of cyanosis, that is decreased saturation in the body of oxygen in the body. Okay, so that is very acute case. On examination, you may find audible wheeze. Bahire bata, you can hear some sound of wheeze. Okay, you don't need to put stethoscope sometime, and you can see the cyanosis. And when you see the respiratory system examination, you may find that there is use of accessory muscles like nasal flaring, subcostal retractions, or suprasternal recession. You may see hyperinflated chest, okay, the barrel-shaped chest, and on the auscultation, you may find decreased airflow or very feeble breath sound or prolonged expiration, and many a times wheezing. Okay, so you may find all these things in respiratory system examination. But what is very important is absence of wheeze, but with increased cyanosis and respiratory distress may mean the worsening of distress. What does it mean? Say, so a wheeze is something whenever there is a narrowing of the airway. But sometimes you may find such a acute case, such a obstructed case that the narrowing is so small that no air is going inside. Okay, so you will not be able to see wheeze. You will not be able to hear any wheeze because air is not entering inside. It's all a silent chest. So whenever you find a silent chest, you have already auscultated the child in the ER, and you were able to find the wheezing. But now what you are saying is you are saying that wheezing is not there. You have already given oxygen, given some nebulizations, and you see the child is more cyanosed. You are giving oxygen, but saturation is decreasing and the distress is increasing. And when you hear the chest, you find that the wheeze is not there. So it's something not to be happy. It's something to be worried, because with increasing distress and increasing sinuses, it means that the distress is worsening. The absence of wheezing doesn't tell you that the child is improving. Okay, it may be more deteriorating. And you may develop cardiac arrhythmias. Pulsus paradox can be seen if the child goes into severe spasm. Okay. So there is a term known as asthma masqueraders, means asthma mimickers. Okay. So sometimes bronchial asthma can be mimicked by other diseases, like bronchiolitis can. Um, so generally, bronchiolitis has similar presentation as bronchial asthma, but bronchiolitis is something viral, and it don't go into chronicity. It will be better by 3 years of age of the child. So as you have already known that it is more common within 2 months to 2 years, but after 3 years generally bronchiolitis doesn't affect the child. So if it is repeated bronchiolitis, we should think asthma, but in the early age, below 3 years of age, you should suspect it may be a bronchiolitis. Okay. Gastroesophageal reflux. So a lot of time reflux may give same symptoms like nighttime breathlessness, nighttime cough, okay, and feeling of chest tightness. So you may be confused. So GERD should always be kept in mind. Hypersensitivity pneumonitis. Some kind of hypersensitivity is there leading to pneumonitis, which may be an asthma masquerader. Foreign body inhalation. So many time foreign body inhalation will give symptoms similarly, distress, cough, and wheezing. But in this kind of inhalation, you will find wheezing unilateral. You will find wheezing on one side only. If the obstruction is on both the sides, the patient's breathing will be very difficult. He will be in very lot of distress, isn't it? Both side airways blocked. But on one side airways blocked, other side will work. But one side he will have symptoms, but milder form, just like asthma. Okay, so if there is unilateral wheezing, we should always suspect there may be a foreign body. Okay, and so with that, what we do an X-ray. If the foreign body is visible, it's okay. If it's not visible, it will show some collapse of some particular area where the foreign body is there. The air is not entering the other points, so there will be collapse. And if you suspect foreign body, then we have to do bronchoscopy and remove the foreign body if you can find during the bronchoscopy. Okay. So then is cystic fibrosis. That will also be mimicking like bronchial asthma, but we see very less cases in our country. Okay. Investigations. So what we do is to diagnose bronchial asthma, we basically do pulmonary function tests. Okay. So, but pulmonary functional tests can be doubtful because a lot of time the child is not able to cooperate to do a pulmonary function test. Generally, in pulmonary function test, the child should take deep breath and hold his breath and then take out a strong breath, deep inspiration and forceful expiration. So that many times the child will not be able to cooperate for this test. So that's why it's doing a little bit difficult. But in pediatric patient, we diagnose more by the clinical examination. So we do pulmonary functional tests whenever there is some kind of doubt that it may not be bronchial asthma in older child when he can respond. Okay. So we do this function test to monitor the response. You have started the patient on treatment saying that it's a bronchial asthma and you want to monitor the response, then also we can do the pulmonary function test. That is, the pulmonary function test should be improving with your response, with your treatment. And the important parameters in pulmonary function test is PEFR, that is peak expiratory flow rate, FEV1. We do by spirometer. FEV1 is forced expiratory volume during the first second. And then we do a FEV1 to FEVC ratio. That is, what is the total forced vital capacity, and what is that out of that vital capacity, what is the amount which occurred in first second. We take a ratio, and that also we compare. See? So if we do peak expiratory, if we do peak expiratory flow rate, we have to monitor this in the morning and evening. And if you see the variation of more than 20% during the morning and evening time, or if the value is less than or equal to 80% of the predicted value for that patient, age and height, okay, then you suspect that it may be bronchial asthma. Plus, if you give a bronchodilator, if you give a puff of bronchial asthma, and there is improvement of 20% of PEFR after the bronchodilation, it means that you should suspect bronchial asthma in this patient. Okay. So basically, we do PEFR by this spirometer. See, so we ask the child to do the child takes a deep breath and do a forceful expiration. Okay, and how much amount he can move this. So this is a knob, small knob. You have to take it to the 0, and the child will do a forceful expiration from here after taking a deep breath, and how much he can take out. Like this is number is 350 in this. Okay, so we do it in the morning and evening, and then we see what is the variation. Okay, so variation more than 20%, or we have a chart of this PEFR for height and age of the child. And if the patient is not having 80% of the predicted value or less than that, then we should suspect bronchial asthma. Okay, so this is the way we do it. Okay, the child is doing. Other is FEV1 and FEVC ratio. Okay, so this one is this pulmonary function. We do it in a computer from this small spirometer. It's difficult to do. This is something we do in computer, and these graphs are given to us by the computerized spirometer. Okay, so if we have low FEV1, or if the FEV1 to FEVC ratio is less than 0.8, then we should suspect that it is a bronchial asthma. Okay. Other investigations is again that is bronchodilator response. You give salbutamol puff, and then if the improvement is more than 12% in FEV1, then you should suspect bronchial asthma. Or sometimes what you can do is you can exercise the patient, ask the child to do some running. Just when you are taking the spirometry pulmonary function test, you can ask the person to do running at the one spot for nearly 5 to 10 minutes, and you will see that after doing that, you will see there is a worsening of FEV1 of more than 15%. So if this improvement with bronchodilator or worsening with exercise, then we should suspect that it's a bronchial asthma. Okay. Other investigations can be a chest X-ray. In chest X-ray, you may find hyperinflated lung because there is an air trapping bilaterally. You can do blood absolute eosinophil count. So as you know, eosinophil is a marker of allergy. So definitely the eosinophil will be increased. So absolute eosinophil count will be increased. And another test we do these days, we hear is allergy test. Okay. So many a times in asthma clinics and allergy clinics, a lot of allergy tests are being advised, but this has very limited role, because in a lot of results, what happens, there is allergy to dust, allergy to cockroach mites, that kind of results come. Or sometimes allergy to almonds, something allergy to some other food. Definitely this kind of result will come. But that doesn't actually help a lot to the patient, because dust allergy is very common. We all know that. And the person cannot avoid dust, prevent the dust in his room. But that is something we do in all cases of bronchial asthma. Okay, so many a times the result of allergy test is not so much satisfying, which finally helps the patient. That's why it has limited role. Otherwise, if you find some particular allergy, like the person is allergic to some particular thing, and you can avoid that thing, and definitely the bronchial asthma attacks will decrease. But the result is very vague kind of result. Diagnosis. So basically the diagnosis of bronchial asthma is clinical. Okay. So repeated episodes of wheezing, repeated episodes of dry cough with chest tightness and breathlessness more at night. If these kind of symptoms are there, you can diagnose bronchial asthma actually. The lung function test will help you in confirming your diagnosis and helping in your treatment. Okay. So, but more diagnosis in case of children, especially in case of children, because lung function test doing is very difficult in children. So clinical, basically diagnosis is clinical. Okay. The absence of physical sign, including wheeze, does not exclude a diagnosis of asthma. Okay, so a lot of times a child may come to you with recurrent cough, breathlessness at night, but you have not ever heard a wheeze. But still, that can be a case of bronchial asthma. Okay, and wheeze does not necessarily indicate asthma. Okay, so wheeze always is not asthma. So as we told you in RD also, sometimes you may get a little bit of wheeze in segment. The treatment is to maintain a normal activity, prevent the chronic asthma symptoms, prevent exacerbations, less or no side effect from the drug therapy. Okay, so our main is, because we are going to give a drug therapy for a long time, we want less side effect or no side effect from them. Okay, so our time is just about to run up. 1 minute is left, but I have more slides, so we should join back. Okay, everyone should join back. Okay, so asthma management is components are basically, first we have to identify and eliminate the exacerbating factors. Okay, so whenever you are managing a patient, you should take a history so much wisely that you should be able to take out if there is anything exacerbating factor nearby. Okay, if you can do that, you are doing a very good job for that patient. That's why doing this is very important. Then is asthma pharmacotherapy. So pharmacotherapy is very easy. I say very easy because this is something which is written in book. We do all the time. The exacerbating factors, assessing and monitoring the patient, and patient education. ACD. This is something which is a skill we doctors should learn with our clinical practice a lot of times. Okay, so B is pharmacotherapy, which can be acute exacerbation treatment and long-term management. Then is regular assessing and monitoring the patient and patient education. Okay. So first one is eliminating and exacerbating the factors. So the time is running out. I will ask you to rejoin, okay?